you have to talk about in this current past as well as the current content. And we do have this program right along the year, as well as especially in the month of September, because the September month is supposed to be dedicated for sepsis, like dedicating a goddess to sepsis. And we have been doing this program also every year. And I think the formal invitation for you all and the introduction of the speakers will be done by our moderator, Dr. Bimal Kudavidanage. Just a word about the sepsis, that as a college, we have taken all the initiative to handle this situation in the country as much as possible. So on behalf of my president, Dr. Anama Pereira, let me all welcome you too. As well as why is this topic is different than the other years is the issue here, or rather an importance here, because as we all know, the guidelines have been changed. Now it started from 2004 to 6 to 8 to 10 to 12 to 15 to 16 to 18 to 21. There had been many changes, and we are duty bound to let you know the newest changes and keep abreast with the newest changes and the additions of the guideline. And especially 2021 guideline is very important to us, because it is mainly they have cached the lower and the middle more than earlier. It was, almost all the management principles were based on the not us, maybe third world countries, not for the lower income countries, but to the others. But this particular guideline is more in favor of the third world as well as developing countries, and the things that we can do and what are the surrogates that we can use. That is because the panel that was involved to the guideline committee this time is very well organized. It is involving all the parameters of the global perspectives, like third, first, second, third, all worlds, as well as the gender equation, the moderators, I mean the normal people, everybody involved. So that is the importance of this guideline. So let me warmly invite our moderator, Dr. Bimal Kudavidanage, consultant anesthetist, National Hospital Kandy, to start the program. Over to you, Bimal. All the very best.
Thank you, Professor Pinto. Am I audible?
Yes, you are.
Can you see me? Because I can't see myself. Right. Anyway. Thank you very much again. And behalf of the Faculty of Critical Care Medicine of the College of Anesthesiologists and Intensivists of Sri Lanka, I would welcome you all for this sepsis webinar. As Professor Pinto explained to you, this is a very important topic, especially in the context of this year and our low and middle income countries. So we are going to give this information, new update on sepsis, which was the guideline was put out last year. And we had our sepsis, the world commemorates the Sepsis Day on 13th of September. So it was some time back, but this month is also named as a sepsis month. So anyhow, it is in the sepsis month. So just to give a few eye-opener why this topic is important, can I share my slides, please? I have few.
Yeah, you can share.
Just give me a moment, please. So can you see?
Yes.
Can see, Bimal, full screen done.
Okay, thanks. So as Professor Pinto says, sepsis is a overwhelming, life-threatening response to infection, and it can lead to tissue damage or organ failure, which even cause death. So it is a basically host response. We will discuss it later. But main thing is sepsis is a medical emergency. We have to know that sepsis is a medical emergency. What is the burden of sepsis? So sepsis is another thing is sepsis is a time killer. So we have few diseases which can cause deaths unless you treat timely, which can cause death. So sepsis is one of those. Others are trauma, stroke, and MI. So this is a very important topic. It's a time killer, so we need to act fast. And the other important thing is there is no simple test to identify this is sepsis. There's no one test to identify this is sepsis. And the cure is for sepsis is there's no particular one cure. So this tablet will cure this, nothing like that. So we need to have a good idea about sepsis, how to identify sepsis and how we should treat sepsis. And if not, what will happen? Currently, worldwide annual incidence of sepsis, this is the latest figures put out by the Sepsis Alliance, World Sepsis Alliance. So current incidence is annually 49 million people get sepsis, whether it is mild or very severe. Out of those, 30% who get sepsis do not survive that episode. So 1/3. In numbers wise, it is about 1 in every 2 minutes patient is dying of sepsis in US. This is we are talking about place where all the medical facilities are available. Okay. Then worldwide annual death is about 8 million. So 8 million people dies in sepsis 1 year alone. So other people who survive, up to 50% survivors suffer post-sepsis syndrome. Therefore, they can't go back to their normal livelihood. So that is the importance of knowing sepsis and treating it, catching them early and treating it properly. And it is the leading cause of death in hospitals if you calculate properly. Then almost 20% people who have been treated for sepsis readmitted within 30 days. Okay. So if you think like that, what is the economic burden? Sepsis is the #1 cost of hospitalization in US. It's cost about 62 billion annually for the US alone. So imagine worldwide cost for treating this disease. And the sepsis is the #1 cause for readmission. And it costs readmission, hospital admissions cost. It is true for every country, even Sri Lanka. With this economic burden, we have to have another additional burden if you don't treat this properly. The funny thing is, 1/3 of the Americans have not even heard about sepsis. But 72% of people in America knows about strokes. They can identify strokes, symptoms of strokes. But only 12% can identify common symptoms of sepsis. So they don't get treatment at proper time. As this is a time killer, this have a lot of burden on our economy and medical profession or the hospitals. That's why we need to learn about this. And that's why we need to have a proper attitude about treating sepsis. And we should carry out those action plans properly. Yeah. One other thing is, this is a very important figure, if I may give you. Risk of dying from sepsis increased by 8% every hour you delay initiating treatment. So if you delay 2 hours of initiating treatment for sepsis, that person's chances of survival comes down from 100% to 80%. So that is the danger of sepsis. Therefore, we have arranged few eminent speakers to talk to you about this very important disease. So, first of all, I would like to invite Dr. Mahen Kotalawala, consultant microbiologist at NHSA, to give about a global perspective of sepsis. Over to you, Mahen.
I think you can hear me. Right. So now, since this is going to be a very practical session, what I thought I think you can hear me, no?
Yes, very
We
well.
can hear you, Mahen. Yes.
So I thought of under global perspective, the trends, global trends in diagnosis and management, and also etiology pathogenesis, to give you some insight on that. So therefore, I have named my presentation as Untouched Areas in Sepsis Management. So basically, I'll be talking about few aspects where we need to improve when we consider management of sepsis. First, I'll be talking about interpretation of culture reports, which we think something that we are lacking when it comes to action. Then I'll be moving to pathogenesis of sepsis, the new insights. Then I'll be moving to sepsis mimic conditions. So there's another conditions which need attention because it might interfere with our management protocols. Then I'll be talking about new and old biomarkers. So then moving to more focused talk on common biomarkers of sepsis used in Sri Lanka and their clinical utility. And then I'll be moving to sepsis management matrix. And then at the end, I'll be talking few words on dose optimization of antibiotics in sepsis. First, interpretation of culture reports. So here we know our hospital setup is organized as such that we are having general hospitals, district general hospitals, base hospitals, and peripheral hospitals, like that. Most of the patients with sepsis first arriving at lower level of care, and later they will be transferring to upper level of care where all the facilities are available. But either you are working in a pinnacle institute or a grassroots level institute, one thing is common. So that is the microbiology results and their interpretation, right? So this is need to be done very carefully if you were to identify sepsis and to institute appropriate treatment. So I am going to discuss about that. As microbes are ubiquitous, that means microbes are all around us, and therefore a mere presence of organism in a specimen may not always be reflective of ongoing infectious process. So that means if you get an isolate, let's say urine isolate in the ICU, and sometimes you might think that you need to cover this isolate, but actually you might not need to cover because of the fact that it would have been something else, not the pathogen, but something else. So positive or negative results requires to be evaluated carefully before any action. So, and any organism can be present in, an organism present in specimen can be a primary pathogen or opportunistic pathogen or a contaminant or a colonizer. So any of these pathogens can present in a one of the isolate culture reports. Correspondingly, the culture positivity could be due to true positive. So now that means the culture positive result is the organism which is responsible for generation of sepsis, or maybe a false positive. So actually it gives us a false sense of etiology, so that we are trying to target that organism. That targeting that organism might have a negative effect on the total care process, because we are not identifying the true pathogen as true. We are getting something else. So sometimes when an infective insult present, you may not get the positive result at all. So you may see it in the ICUs. So we are definite that the patient is having some sort of an infective insult and having sepsis, but whatever the cultures that you do, that becomes negative. So in that scenario, you are getting a false negative result. This makes diagnosis of infectious diseases extremely challenging, because we don't know about the etiological agent. So in countries like Sri Lanka, where diagnostics are not to the level of international standard, we are finding it more difficulty in elucidating the etiological agent. So therefore, usually we tend to use antibiotics more and more, instead of identifying the organism and targeting the organism which causing sepsis. So this is a bad way of management because of the lack of diagnostics in our scenario. As culture results have to be interpreted in relation to the clinical context of the presentation. So because of this fact, the diagnosis of etiological agents of sepsis become a very challenging issue. For example, a gram-positive blood culture isolated from a single blood culture may not be clinically relevant. So because you might think that this may be a significant pathogen, but actually what you have got is a probable contaminant. Because of the fact that you have taken only single culture, it's very difficult to identify whether the organism that you have isolated from blood culture is the true pathogen or not. So generally, I think almost larger number of hospitals, even if they embark on blood culturing, they are not doing it as recommended in protocols. So you have to have multiple sets of blood cultures in order to catch the etiological agents. But because of financial constraints and the current situation in the country, we are not in a position to spend more than one blood culture for a person. So therefore, what we are getting, the results we are getting, we are not in a position to institute the appropriate treatment. Hence, antibiotic may not be required for this case if it is a false positive isolate. In the same organism, if a gram-positive organism become positive on several samples taken at different time intervals or repeatedly isolated from same treatment. So now this scenario is a bit different. So therefore, that means you are getting the same isolate over and over again from the same person, or you are isolating the same organism in multiple samples. So therefore, this is most likely to be a significant isolate, and you can institute antimicrobials against this isolate. So the scenario is different. So in contrast to gram-positives, if you isolate a gram-negative bacterium from a single blood culture, so that has to be considered as significant and you need to institute treatment. So in this scenario, we might be able to target our antibiotics. So generally, we are starting with empiric antimicrobials on the best guess basis. And if we, once you get the culture report, we are planning to target and switch over to a more narrow spectrum agent. But when you are having a gram-negative organism, your certainty of that being the pathogen is high. Therefore, you can omit the gram-positive drug and continue on the gram-negative one, which is given to the patient. So gram-negatives or gram-positives isolated from tracheal secretion. So this is something that we are getting in ICUs most of the time. So one positive culture that we are getting is the tracheal secretions. But mere presence of organisms in tracheal secretions do not warrant treatment. So therefore, you have to consider this thing as a in clinical according to the clinical presentation. Again, any growth from sputum. So you have to interpret it in very carefully. So if somebody has taken 1 or 2 days of antimicrobials, if you do a culture on that patient, so you will get a multi-resistant gram-negatives from that person's sputum. So it is of no use, and you need not to embark treatment on that, because that is more likely to be a colonizer which left after other organisms have died. So in that scenario, you don't need any action for that. But remember, tracheal secretion and sputum, most of the time, they are giving us a wrong impression on the pathogen. Wound swabs. Wound swabs giving another thing, surgical scars and wound swabs. Again, if you isolate a multi-drug resistant gram-negatives or any other organism from wound swabs, a chronic wound swabs, that may reflect to be a colonizer. So if there is no evidence of inflammation surrounding, you don't need treatment. So then again, it's similar to the positive urine culture. Again, in ICU patients, they are catheterized. And when you tend to culture as a part of the septic screening process, you will get a positive result. But actually speaking, if you interpret it very carefully in context to the patient's clinical presentation, this may be a just catheter contamination or a colonization, which need not to take any action against for. Then again, wounds of gram-negative bacillus from surgical site or surgical drain may need not to be considered for treatment, because when you put a when is there a wound or when there is a drain, the natural process is all organisms which is from the patient's body or the healthcare environment, they colonize these places. So therefore, invariably you will be getting some sort of culture, most likely a resistant organism, and you need not to take any action for that unless there is evidence of inflammation around the wounds. Again, candida from sputum or tracheal secretions. This is also a normal happening throughout the world. You can see a lot of patients in ICU who are being ventilated and who are extensively investigated for sepsis, giving a positive candida result when you culture the sputum. So the natural tendency is to start antimicrobial treatment. So now, if the agent is candida, pneumonia causing agent is candida, you will get a very high mortality, and under our circumstances, it is very difficult, even if you start antifungals, to recover the patient. But most of our patients, the candida coming from sputum or tracheal secretions tend to be colonizers or left along organisms after you institute antimicrobial therapy. So therefore, unless there is a specimen taken from lower tract, and if there is a considerable number of organisms, you need not to start treatment onto this thing. But candida, if candida coming from intra-abdominal collection or a blood sample, even the patient is asymptomatic, even the patient is not having symptoms, you need to start treatment. So that is the nature of candida infection. So other thing is the CVP tips. So generally in ICU, so other areas where the critical care is provided to patients, you tend to insert central lines. And at the same time, when you remove the central line, you tend to send the tip. So generally, all central line tips become positive, because that is a part of natural process. After 48 hours of inserting any line, the lines can be colonized with organisms. So therefore, invariably, they will get the disease. Unless the peripheral blood is not positive with the same organism, you need not to embark on treatment. Right. But that is not reflective of a true pathogen. Some microbial tests that we do in ICUs and in the hospital setup, so they need to be quantitatively analyzed, and other tests are just qualitative. So, for example, bronchoalveolar lavage, protective surface brushings taken from lower respiratory samples, and urine has to be interpreted quantitatively. The mere presence of organisms, you need not to start treatment. So, a mere positive results may not be significant unless the diagnostic cutoff is exceeded. For example, if you are looking at a urine sample, it has to be usually more than 10 to the power 5 on a patient who is not catheterized. So when the catheterization comes into that, so you have to repeat the culture after removing the catheter and collect another sample, and for interpretation, you need to have 2 cultures. But when it comes to bronchoalveolar lavage, mere presence of organisms are not an indication for treatment. So this is evident where we are getting more bronchoalveolar lavage samples. We are getting more bronchoalveolar lavage samples, but almost all were contaminated or colonized with gram-negative Pseudomonas species. So therefore, if you start treating those patients, it will be just misuse of the antibiotics that we are having, and that will create unnecessary pressure among organisms to develop resistance. Blood, CSF, intra-abdominal collection, joint fluids, and cultures, they are interpreted only based on qualitative manner. So that means any positive culture coming out of them, you have to consider it as significant. But again, you have to be very careful when you are interpreting the culture results, because there's a possibility of contamination during collection and transportation. So they may have a negative impact. For example, if you are taking CSF sample from a EVD which had been in situ for a longer time, invariably you will get a positive culture. So if there is no corresponding clinical features or corresponding pus cells in the sample, you need not to cover that organism. So therefore, it need to be interpreted very carefully. So therefore, a careful evaluation is necessary for a positive culture before embarking on treatment. So now this article shows that reducing blood culture contamination rates experience of 4 hospitals. So there it is, blood culture contamination rate. Contamination is a universal phenomenon, be it in USA or be it in a country in African continent or in Sri Lanka. The blood culture contamination is a very common phenomenon. So therefore, if you want to interpret it carefully, so you need to look at the clinical context and also the syndrome that you are suspecting before embarking on treatment. So now we move to the pathogenesis of sepsis. So this is very straightforward. All sepsis has to initiate with some sort of infective insult. So with the infective insult, there will be a lot of changes within body, and if it is not controlled carefully, the infection will leads to this vicious cycle of organ dysfunction and leading to organ failure, and ultimately it will lead to death. So pathogenesis of sepsis involves cascading response of various mediators produced by host. The first step of genesis of sepsis is the recognition of molecules, the patterns of the pathogen by the host receptor molecules. So that is known as this pattern recognition receptors, which are there on the surface of the immune cell. So they were recognized. These were recognized the specific sort of molecules on the organisms, which is known as pathogen-associated molecular patterns. Once these pathogen-associated molecular patterns were identified by the immune cells, they will mount the immune response against the pathogen. If the immune response occur in a controlled manner, there will be recovery. But if it is dysregulated, the immune response lead to unopposed action of the inflammation and immune suppression. So that will lead to organ failure and death. So that is the normal pathogenesis of sepsis. So, right. So again, acute tissue damage. So if there is acute pancreatitis, or if there is any vasculitis, or if there is burn. So acute sort of tissue damage, that will also brings up the similar immune response. This immune response is mediated by molecules known as DAMs, damage associated molecular pattern. When it comes to DAMs after tissue injury, so these were detected by the different pattern recognition molecules, and then the immune cells will produce a lot of mediators. And if these mediators were controlled by the body, there will be recovery. But if it is not controlled, and if it allowed to overwhelm the body's immune system and the organ system, it will lead to organ failure and death. So now this scenario, not due to infectious, not due to infectious agent, but it shares the same mediators as in sepsis. So if the response due to tissue damage is dysregulated, this leads to condition known as catastrophic inflammatory response, as you've seen in vasculitis, acute pancreatitis, and acute fulminant hepatitis like scenario. And this is a killer condition, and sometimes we might misidentify this as sepsis. So the important thing is sepsis, you can't differentiate it clinically on the basis of clinical symptoms. Both sepsis and catastrophic inflammation share the same downstream mediator. So that is after identification of this pattern, by the identification of by the pattern recognition molecules, the subsequent response, they share same downstream mediators. Therefore, they will have, both conditions will have similar clinical presentation. All the effect of sepsis and catastrophic inflammation are secondary to microvascular failure. So we know there are two things in sepsis manifestations: the macro changes where you can monitor, and the other things where you can't see. So these are due to microvascular failure. So here are the microvascular failure in sepsis, and what are the other events associated with microvascular failure, which leads to this cascading effect of cytokines and the overwhelming response of the dysregulated immune response. So these are the things which involve in pathogenesis of sepsis, and it is a very complex, and even now you are getting more information about this pathogen. So we will move to the sepsis mimic condition. As I have mentioned earlier, sepsis and there are sepsis mimic conditions, both can present similarly into medical casualties. Sepsis mimic condition occur due to secondary to the dysregulated immune response, and it is not initiated by infection. So when you consider the definition of sepsis, it is due to infection. But here, the sepsis mimic conditions are not due to infection, but due to tissue damage. Antibiotics do not play a role in management of sepsis mimic condition. So now, generally, our natural tendency to treat this patient with antibiotics. Any patient presenting with this sort of symptoms with antibiotics, but it is no problem giving the antibiotics, but you have to look into the possibility of encountering one of the sepsis mimic conditions where treatment will be different. So important sepsis mimic conditions, I have listed out here. You can see surgery, trauma, hematoma, myocardial infarction, transplant reduction, pancreatitis, vasculitis, severe burns, thyroid storm, transfusion of incompatible blood fluids, GCSF therapy, malignant hyperpyrexia, immunotherapy, tumor infiltrating cytotoxic and hypernephroma, tumor lysis syndrome. So there are a whole lot of things which present similar to sepsis, but actually the pathology is not due to infectious agent, and therefore you need to have a look at the possibilities of these things. So then what are the role of biomarkers in sepsis? So early recognition and aggressive therapy has shown to improve the outcome of sepsis, as Dr. Bimal said. So if there's any delay in identifying sepsis, there will be increased odds of dying from sepsis. So therefore, early identification is very important. Sepsis markers are extremely helpful to early diagnose sepsis, right? So before clinical symptoms appear, there are changes which happening in the subcellular level. So that can be detected with septic markers. So therefore, when you are managing sepsis, it is invariably sepsis biomarkers will have a positive impact in your management protocols. Sepsis biomarkers are also helpful to differentiate sepsis from other sepsis mimic conditions. So especially in patients who are coming to medical casualty with acute pancreatitis, some sepsis markers will be very important in managing the patients. So sometimes you naturally might feel that why do we invest on sepsis markers? So they are very costly tests here. So that is our natural feeling when you want the sepsis marker to be introduced into your laboratory repertoire. But when you consider the cost associated with management of a patient with sepsis, the cost of sepsis markers are not to be considered as significant. So that has to be considered when you are planning to have a test sepsis on sepsis biomarkers. So when you have biomarkers, there are two types of biomarkers. One is pathogen-derived markers. The second one is host-derived markers. The pathogen-derived markers means the markers which are coming from the pathogen. So the blood culture and the other cultures that we do is to identify the organism, the living organism. So generally, the major drawback of this biomarker is it will take time to detect. So then you can go for antigens, you can go for PCR or antibody response. But naturally, serology is not considered as a good biomarker because it is a late marker, unless you are dealing with something like atypical presentation of dengue or atypical presentation of COVID. So usefulness of antibodies are very much limited. But our gold standard in diagnosing sepsis is the demonstration of living organism from the cultures. But again, as I mentioned earlier, the cultures has to be interpreted in relation to the clinical scenarios. So then the next group of markers are the host derived. So that is the host response. So host in relation to the infective agent, host will have several responses. So you are trying to demonstrate these host derived markers in order to identify, to have some idea about the changes happening in sepsis. So there are two types of host-derived markers, the conventional markers and the new molecular markers. The one that we know are the conventional biomarkers. So up to now, there are more than 200 conventional biomarkers which are categorized under 6 broad groups. So these are these groups. You can see there are acute phase proteins, there are cytokines, there are soluble receptors, there are biomarkers related to vascular endothelial damage and biomarkers of vascular vasodilatation, so and so. So these are around more than 200 vascular biomarkers available for diagnosis of sepsis. But some may have advantages and some may don't have that much of advantages in when you are diagnosing sepsis. So therefore, we have to know the utility of individual biomarkers if we are using them to manage sepsis. So as described earlier, so there are no universal best biomarker. So biomarkers, that they may vary. So whatever the disease condition that you are suspecting, biomarkers may be different and you have to use in relation to the context. So then the next thing is the new molecular biomarkers, and there are 4 groups of new molecular biomarkers. Most of them were based on detection of host response at gene level and also host response at protein synthesis level. So now these molecular biomarkers are very important because they rise rapidly in the early stage of sepsis, and also these markers, unlike the conventional markers, can be used to identify pathogens, especially this RNA biomarker, that is transcriptomic analysis, which is known as blood leukocyte transcriptomic profiling. So that can be used to diagnose early sepsis early, as well as roughly to identify the organism which causing sepsis. So it can diagnose whether it is a gram-negative organism or gram-positive organism, fungus or virus or a parasite. So that comes very handy, and it is described as PET in sepsis diagnosis. That is PET, just like a photon emission tomography. So that has revolutionized the imaging. And likewise, these RNA biomarker, transcriptomic biomarkers are revolutionizing the sepsis diagnosis and sepsis care, because it will helpful to identify the etiological agent right at the beginning of pathology process, so that you can detect sepsis early and institute treatment. These pathogen-derived markers are so the first one that I have discussed, the pathogen-derived markers. So they are helpful to institute targeted treatment. So we are starting with empiric treatment, and we can convert it to targeted treatment based on the pathogen-derived biomarkers. The blood culturing that we are doing is pathogen-derived biomarkers. So what are the common markers that we are using here? So there are three markers that we are using. One is WBC-DC and neutrophil count, CRP, procalcitonin, and multi-marker approach. The multi-marker approach is one of the latest approach where you use more than one marker along with patient's clinical symptoms to identify sepsis. So that will have a higher specificity to diagnose sepsis. So basically what we are using is the WBC-DC, CRP, and procalcitonin. Procalcitonin only in limited number of hospitals, but procalcitonin is limited number of hospitals, the facilities available, and most of other hospitals are dependent on other two biomarkers, WBC-DC and CRP. So what is the utility of WBC-DC? The utility of WBC-DC, it is actually of no use in detecting sepsis or it is trajectory, right? So it fails to discriminate sterile and non-sterile information. It does not have any prognostic or diagnostic significance. And when you are encountering a neutropenic patient, you can't rely on WBC-DC. So therefore, contrary to our belief, WBC-DC does not give any idea about what is happening in the sepsis. So therefore, it is not considered as a sepsis marker. So if you go through this graph, if you know to interpret this ROC graph, you may see that WBC-DC, it's going along this undifferentiated line. So therefore, any test which is going like this is not useful in detecting sepsis. So WBC-DC goes along this of this undifferentiated line in ROC curve. So therefore, it is not useful in detecting sepsis. But procalcitonin and CRP can be used at some extent. C-reactive proteins, and it has the major deficiency that it fails to differentiate inflammation from infection. So it detects stressful condition, and therefore in inflammatory conditions as well as infection, CRP will go up, and you can't differentiate sepsis from non-sepsis with the CRP. Right. General recommendation for CRP for biomarkers, it has a role when there is no other effective biomarkers available, and it requires serial testing and generally preferred over PCT due to its lower cost. But again, we have to understand that CRP has a half-life of nearly 18 hours. So therefore, it is no use of repeating CRP daily, but you have to give some time for CRP to come into balance with production and destruction. So we'll move to procalcitonin. Procalcitonin is a good predictor of bacterial infection. So that had been identified as a good predictor of bacterial infection throughout the world. And PCT exhibit greater sensitivity of 85% and specificity of 91% in differentiation patient from systemic inflammatory response with that of sepsis. So any inflammation and sepsis, you can use procalcitonin to differentiate it. So what are the clinical uses of procalcitonin? So it is worldwide, FDA has approved procalcitonin use in risk assessment in conjunction with other parameters in ill patients who are receiving ICU care. So that means when there is FDA approval for risk assessment, so you can use it because it had generally FDA gives it authorization after careful evaluation. And it has to be, PCT has found to detect systemic bacterial infections. So even the cultures are negative, still you can detect systemic bacterial infection with PCT, and you can have an idea about what is happening inside the body. PCT can be used as a point of care test in emergency treatment unit. So again, when it comes to the concept of ETU, PCT comes in handy. Patients who are coming to ETU in shock situation, you can do PCT as a point of care test and have an idea whether the patient is having sepsis or not. And in that way, you can economize using antibiotic. At the same time, those septic mimic conditions can be excluded, and the patients can get the proper and ideal care of their clinical conditions. So what are the limitations of PCT? PCT in our scenario, it is more costly than CRP. But PCT is not, although it is useful, it is not a all or none test. So that it doesn't give a good discrepancy, a good differentiation of sepsis. Again, you have to use it in relation to patient's clinical scenario. So what are the major limitations of procalcitonin? You can't use it in neonates because it is not validated, and you can't use it in major degree burns, and also after trauma, major trauma or major surgery. PCT are not validated to measure what is happening inside the body. So what are the evidence available favoring PCT-based decision-making in clinical practices? Evidence 1. So the famous Kumar and Clark graph. It says early identification of sepsis will have a good outcome. So this is the evidence number 1 for utility of sepsis. So if you use sepsis, there's a chance that you can identify sepsis early. With the early identification, you can institute an appropriate antibiotics so that sepsis will be controlled. Procalcitonin provides critical biomarker information that can be helped to increase the accuracy of early sepsis diagnosis. So therefore, you are in a win-win situation. Evidence 2. Risk stratification of patients who are likely to end up in poor outcome. So again, in a country where intensive care facilities and HDU care facilities are limited, the risk stratification of patients are very important, especially to identify patients who are having a poor outcome. You would have noticed it during COVID times, how important our HDU and critical care beds were. So we had to identify patients who are having a poor outcome and also who might have a good outcome when you are instituting the proper care. However, you think it is it is irrational to risk stratify, but because of the limitation of our resources, at some point this risk stratification has to come into action. So there's a trial is known as study known as multi-center procalcitonin monitoring sepsis study trial, a MOSES study in 2017. So they have found that if the procalcitonin level drops by 80% on day 4 compared to admission, it might have a positive outcome benefit. So that is a good outcome. If the drop of procalcitonin level from admission to the 4th day, if it is more than 80%, so that means the patient is having good outcome. And if the drop is less than 80, the patients might have a poor outcome. So these are the evidence to show that it is have the ICU patients. So the mortality in ICU patients, the PCT guided treatment group is higher than PCT. Here it is 80% drop, the green color, no 80% group drop in red color. You can see there is a definite 28-day mortality advantage with the people who are having 80% drop of procalcitonin compared to the procalcitonin level of admission. But when it comes to non-ICU patients, that advantage is not so marked. So therefore, according to the available evidence on this basis, we can recommend procalcitonin-based treatment for HDU and critical care patients. So then again, drop of procalcitonin, you can see on total subjects, that is both ICU and non-ICU patients. When you compare both together, still there is distinct advantage of procalcitonin guided. It is evident that when the percentage change of procalcitonin is less than 80% in 4 days, the outcome had been poor in all groups. So evidence 3, procalcitonin guided therapy in pulmonology. So that is pneumonia. The procalcitonin is a very good marker for pneumonia and its complication. So you can see, according to this measuring, it definitely shows that the procalcitonin guided therapy is better in this thing, and it is a non-inferiority trial. Evidence 4. So antibiotic exposure and procalcitonin. Here you can see if in the ICU setting, this is antibiotic exposure. In procalcitonin guided treatment group, the antibiotic exposure is less compared to procalcitonin not guided team. So therefore, you can see procalcitonin can be used as a tool for antimicrobial stewardship, and that is very well documented in scientific lesson. So procalcitonin group shows significant reduction of antibiotic exposure than the control. So you can see 23% reduction in antibiotic exposure in PCT guided treatment group. Largest reduction of exposure is seen in emergency departments, because you know the patients are coming with the emergency, and if you do procalcitonin guided treatment, the reduction, the survival is definitely going to be best with the emergency departments. So the reduction of ICU stay, again you can see significant difference seen in developing countries than developed countries. You can see developing countries means countries like us. If we are opting to treatment based on PCT, procalcitonin guided therapy, we can preserve ICU beds. So if the test cost for procalcitonin is 5,000 rupees, and what will be the cost of saving 1 day of ventilatory bed in ICU? So you can't imagine the cost difference between the two groups of treatment. Then again, 28-day mortality, you can see significant difference in developed countries than in developing countries. Again, 28-day mortality, if you manage patients with procalcitonin base, it will be high. So now I'll move to the next thing, is the sepsis management matrix. So when you are managing sepsis, there are two arms. One is the source control arm and the resuscitation arm. All these guidance at the ETU and HDU and ICUs are based on the resuscitation. So these fluid management and everything, fluid management, inotropes, every monitoring, everything based on resuscitation. But what about the major part you have to give is the source control. In source control, there are two things. One is identification of source and the source management. Identification of source in the sense that you have to do microbiological investigations plus targeted imaging. So there are major term among us called sepsis screening, septic screening. Septic screening means both those things. There are no universal septic screening. Always you have to use the microbiological investigations with targeted imaging, whether it is ultrasound scan, whether it is PET or MRI, but you have to use them in conjunction with bacteriological investigations, that is to identify sepsis. Then the second arm is source management. Source management have two arms. One is antimicrobials and the second one is drainage and removal of the source. So when it comes to antimicrobial, there are two ways of treating: empiric therapy and targeted therapy. Again, microbiological samples are important in identifying this. Right. So antibiotic optimization. So I'll just rush through this. Sepsis brings about many changes in body's physiology. So invariably, it will have some effect on pharmacokinetic and pharmacodynamic properties of antibiotics. So they are markedly changing, and sometimes as a result, you may underdose the patients, right? Especially when you are trying to dose optimize with Grocott formula or any other arbitrary measures. So there are evidence to show that antimicrobial concentration are lacking, are less than that of the optimal level. So with the sepsis, you can get distribution issues, protein binding issues, drug clearance, drug metabolism, and the spectrum of coverage, target site concentration and activity, and the interaction of drugs. Sepsis and septic shock alters all these parameters. So adjustment of antimicrobial therapy according to this change PK/PD in order to achieve maximum therapeutic benefit without toxicity is known as optimization of antimicrobial therapy, where we need to embark on. So that means we are giving right drug at right time in right doses. So most of the time when we are trying arbitrarily, right? So all recommended doses are given in relation to the healthy volunteers, and all these antibiotic guidelines, the BNF and all those protocols gives the dose in relation to the normal individual with normal physiology. Say they don't consider all changes associated with sepsis. So therefore, arbitrary changes of drug levels according to some arbitrary parameters like serum creatinine or estimated renal clearance may negatively impact the patient's clinical condition. So there is another concept called augmented renal clearance in sepsis. So here the kidney demonstrate increased filtration, and as a result, even the normal doses, if you give the normal doses, you might not get adequate concentration in patients with augmented renal clearance, especially conditions like sepsis. So in sepsis, sometimes you need, in order to counteract this augmented clearance, you may need to introduce loading dose in order to negate these physiological challenges. So objective of this optimization is to achieve rapid bacterial clearing before irreversible changes sets in. So it includes the early aggressive therapy. So how to optimize therapy? So these are the things, starting with de-escalation and treatment based on point of care testing, then try to direct the treatment, targeted treatment, and then we have to guide our antimicrobial therapy and other resuscitations based on inflammatory markers, monitoring the therapeutic response with drug levels, monitoring the side effects and adverse drug reactions with the drug levels as also end organ damage, adjusting the dose according to the changes that you anticipate in sepsis, and source control. Without source control, you can achieve a good outcome. Then the proper infection control practices. So that is to prevent hospital-acquired infections in hospitalized patients who are being treated at ICUs, and also antibiotic stewardship programs are necessary for dose optimization. So again, this graph clearly shows that de-escalation, which is given in blue color, will have a higher 30-day mortality in compared to no de-escalatory therapy. So therefore, there's a definite role of de-escalation in antimicrobial susceptibility. So other frequently non-discussed topics that we need to discuss later is the point of care testing, antibiotic stewardship, and diagnostic stewardship. So these also need to be discussed when we are managing sepsis. Thank you very much.
Thank you very much, Dr. Mahen, for that informative lecture. And I would like to inform that we will take the questions at the end of the two other presentation or discussion as well. So please do send the questions on the chat box. Now with that updated knowledge on sepsis pathophysiology and the sepsis diagnostic biomarkers to detect sepsis early, we will go to the main part of our discussion today to discuss current 2021 sepsis guideline with update, and with the help of a clinical case. So we will be discussing a clinical case with the 2021 update, and it is my pleasure to invite our colleagues who are clinicians who are working in ICUs to discuss this case. Dr. Harini Jagoda, consultant anesthetist at District General Hospital, Ambilipitia. Dr. Amila Jayasinghe, senior lecturer, Department of Anesthesia and Critical Care at the University of Peradeniya. And Dr. Anushka Senaviratne, consultant anesthetist, Police Hospital, Colombo. And I would like to specially thank Professor Vasanthi Pinto for giving us guidance on this case discussion. And also Dr. Mahen Kotalavala, the consultant microbiologist at NHSL, will also participate in this discussion for this case discussion. Over to you, Dr. Harini and Dr. Amila. Dr. Harini.
Yeah.
Thank you, Dr. Bimal. So we are going to talk about sepsis, new guidelines and its management using a case scenario. Just to give a small introduction of sepsis, I would like to invite Dr. Anushka, and then we will move on with the case discussion. Anushka?
Yeah, so I think we discussed what sepsis is. Dr. Mahen beautifully introduced what sepsis is, but we will emphasize on the sepsis definition. We need to know the definition because for us to identify sepsis, for us to recognize sepsis, we have to know what sepsis means, so that when I say sepsis, it would mean the same to any other person who is across the country or around the globe. So to have a uniformity of diagnosis of sepsis for recognition purposes, they have given a definition for sepsis and of course septic shock. So these definitions for sepsis, the terms have been evolved since 1992. What we use is 2016 definition by the Third International Consensus Definitions for Sepsis and Septic Shock, which is recommended to be used in 2021 guideline as well. So for us to say sepsis, as Dr. Mahan said, there is infection, and then you have your host, and then you have your organs. So if the infection comes into the host, and if the host immune system has been successful, he would be cured. But if the immune system is not successful, and when it starts its dysregulated immune response, it would have detrimental effects on our organ system. So there would be a dysregulated or immune system causing a life-threatening organ dysfunction to response to an infection. So this is the definition of sepsis. So if we move on, so these end organs, we all know these could be the end organs: the neurological system, respiratory, hematological, renal, hepatic system, cardiovascular system. So these end organs would have their own effects, own manifestations. Apart from this, our skin, soft tissues, bowels, peritoneum, bladder, any organ system could be involved depending on the infection and this dysregulation in the host response. So moving on to the septic shock, it is a subset of sepsis. They have given this definition of septic shock to say that the patient is at a profound state, that is their circulatory, cellular and metabolic abnormalities are very profound. So it would increase the morbidity and mortality. So this is the definition, but clinically we identify the patients who are at septic shock if the patient is having persistent hypotension, who requires a vasopressor to maintain their mean arterial pressure more than 65, and despite adequate resuscitation, if the patient's lactate levels are more than 2 millimoles per liter. So that is about sepsis and septic shock definition. So these sepsis and septic shocks are subsets of infection. We could relate increased morbidity and mortality in the particular patients. Yes, Anu.
Right. So, Anushka, we will move on with the case discussion. Anushka, there was a patient, 60-year-old patient in the poly ward. He's a ASA2 patient with diabetes, hypertension, and smoking, and underwent a laparoscopic anterior resection. No intraoperative problems as such. But on post-op day 3, the patient developed fever, and the patient was complaining of feeling ill and nausea and vomiting. So a nursing officer was very concerned and called the medical team because of these parameters. The pulse rate was 110, patient is tachycardic, and the blood pressure is quite low, 85/60. Saturation is also low, 92, and the patient, they have started the patient on some oxygen, and she had noted a fever spike as well. So with these, positive signs, the nursing officer called the medical team or the surgical team who were attending this patient. So they thought, okay, this is an emergency. We need to resuscitate this patient, assess and resuscitation in the ABCDE manner. Meanwhile, they had a query whether this is sepsis because the patient is having now fever on post-op day 3, and the blood pressure is low, tachycardic. There are, deterioration of the vital parameters. So they thought, okay, we have a patient who is critically ill. We should start treatment, and also we should start screening for sepsis as well, and start managing the infection if there is an infection, and managing the circulatory failure. So Anushka, this is the initial resuscitation given in the ward. The patient's airway assessment, he was spontaneously breathing and talking, but the patient was tachypneic. Her respiratory rate was 29. The equal chest expansion was there, few coarse basal crepitations. Now the saturation has improved to 98 with 40% oxygen. However, patient has very cold and clammy peripheries, tachycardic, low blood pressure. The doctors have now, put a large bore cannula and taken blood for BBG and basic investigations, plus a blood culture was taken. And fluid bolus 500 ml was started. And they have decided to give IV meropenem 1 gram stat dose as well. On assessment of D, patient was conscious and rational. Blood sugar was 240. And they found that the abdomen was tense and tender. It's distended. There was no bowel sounds. And the patient had a fever spike. Now, Anushka, with these findings, how would we suspect or screen for sepsis in this patient? Are there any screening tools for us? And are there, specific advantages and disadvantages of these tools?
So it's obvious that in this patient, it's likely he's having sepsis, abdominal sepsis, or pathology with a respiratory infection as well. Yes, to talk about this screening tools, I think we all are familiar about this quick SOFA score, which was introduced as in 2016 guidelines. So it is a screening tool which is being used, which we have been using since 2016. So the mnemonic to remember this is HAT, whether the patient is having hypotension, altered mental state or the GCS, and the tachypnea. So if the patient has had 2 or more rise from baseline of these 3 parameters, we took it as a positive QSOFA or a SOFA. SOFA means sequential organ failure assessment, or sepsis-induced organ failure assessment. So 2 out of 3, if it is positive, we said that patient has had this SOFA. But this QSOFA was initially developed to say the morbidity, and to say that the patient has increased morbidity and mortality in a suspected patient who is having sepsis. So, but it has been used as a screening tool ever since 2016. But the current guidelines, 2021 guidelines, they have said this QSOFA is they have issued a recommendation against using QSOFA alone. So mind you, here the QSOFA is not completely discouraged. You can use QSOFA, but you can't use QSOFA as a sole screening tool, because they have found that its sensitivity is less. So though the specificity is good for QSOFA, when a screening tool, when it has less sensitivity, so you would not be able to catch a lot of positive patients who are truly positive. Say for an example, you have 100 patients who truly have sepsis, but this QSOFA would diagnose or detect only about 60 of them. So it is about 60%. So because its sensitivity is low, 40% or 40 of the people would not be identified as having sepsis. So QSOFA, you can use it, but you should, if it is negative, if QSOFA is negative, you should not regard the patient as not having sepsis.
So Anushka, our patient, there were 2 criteria positive. The patient was hypotensive and tachypneic, but the patient's conscious level was okay. So 2 are positive, so it's a positive QSOFA score. So as we can see in this graph, it says that the patient has a poorer outcome, isn't it? Now, because you said that this is not the sole screening tool, are there any other tools that we can use?
Yes, the other tool is this LQ-SOFA or lactate Q-SOFA. So this is not included in 2021 guidelines, because as we are talking about sepsis screening tools in a broad perspective, So some stations or institutes would use this LQ SOFA score if you have the luxury of doing a lactate level. So if you suspect the patient having sepsis, but he has only one Q-SOFA criteria. So if you can do a lactate level, and if it is more than 2 millimoles per liter, you could come into a diagnosis, or you can screen this patient as having sepsis. But mind you, this lactate, you have to interpret according to the patient's background, whether there are other causes of rise in lactates, but you can have a diagnosis. For this, the level of evidence is low, but the quality of evidence is good for this LQ SOFA score.
Right. So Anushka, the blood gas, a blood gas was done on our patient, and it says the lactate is 4.5. Right. As you can see, as you already explained, so our patient has a positive lactate and positive Q-SOFA as well. So there is a very high possibility of sepsis and a higher risk of bad outcome as well, because the patient is already in lactic acidosis. Now, this is another tool that we have already heard about, sepsis SIRS criteria. Is it now again coming into play, Anushka?
Yes, SIRS was the first cost criteria which was introduced with this consensus of sepsis. So it has been used since 1992. So you had these 4 criteria: tachycardia, tachypnea, fever, leukocytosis, leukopenia, or bandemia. So if you have evidence of infection plus 2 of these 4 criteria, initially it was diagnosed to have sepsis. But later on in 2016 guidelines, they discouraged use of SIRS criteria, because it's obvious that this tachycardia, tachypnea, and fever, they would not emphasize any dysregulated life-threatening response, or it would not emphasize any life-threatening end organ dysfunction. So this Sepsis 3 or 2016, they have discouraged use of SIRS criteria. But in 2021 guidelines, again, what they say is SIRS is better than Q-SOFA. So you should not use Q-SOFA alone. So you can use Q-SOFA, SIRS, both together, and to make sure you have a low threshold to catch these high-risk patients who are having sepsis.
Right. Yes, Anushka. So our patient had 3 criteria positive, and we are still awaiting a full blood count. So temperature, pulse rate, respiratory rate, all 3 are positive. So there is definitely some inflammation going on. We are not very sure whether it is sepsis or any other focus of inflammation, but it's definitely alerts you. It says something is going wrong in the patient. But according to the sepsis definition, it talks about organ failure. This patient is already on organ failure. The blood pressure is quite low, but this does not count that organ failure into the scoring system. What about the SOFA score, Anushka? Can we apply that as a screening tool? Is it too early to apply a SOFA score now?
Actually, SOFA score was developed before this Q-SOFA, this sepsis-induced organ failure assessment score. So you have 6 organ systems where you have given marks for individual organ systems according to the physiological parameter which the patient is having. So if you have evidence of infection plus change in the SOFA score by 2 or more points, mind you, it's change in the SOFA score by 2 or more points, you can diagnose the patient as having sepsis. But if you go to this graph, you see it's rather complicated, and you may need certain investigations for you to diagnose this as sepsis. So it is wondered whether this SOFA score is suitable to be used as a screening tool, because screening, when you mean screening, it has to be you should be able to diagnose it by the bedside, or by the OPD, by the ETU, by the ward side. So this is a bit complex, and it is poorly situated, suited for these low and middle income countries. And the other thing is, you need to have investigations then and there. Suppose you suspect sepsis now, but the investigations available will not tally with the investigations right now. It may be the investigations done the other day, or you may already have sent investigation and awaiting the investigation. So it is not suitable for a screening tool. And of course, sometimes the baseline scores may not be known. The patient may be having already impaired organ dysfunctions when he had this sepsis. And of course, if you look at this graph, they use dopamine for this cardiovascular physiological parameter description, which is currently not recommended. The current recommendation is noradrenaline. So this also is, you can use SOFA score, especially if the patient is in ICU, but not as a screening tool.
Yeah. So Anushka, our
Yes,
patient,
yes.
the problem is we are still awaiting investigations. This is at a very early stage, and the patient was just catheterized, and we only know the initial urine output. We still don't know the hourly urine output. So to use SOFA score, we need further investigations and further assessment. So it's not really a screening tool when we initially detect a critically ill patient. Now, our patient fulfills CIRS criteria, Q-SOFA criteria, LQ-SOFA criteria. But don't you think, Anushka, that we have missed the golden hours? I mean, the blood pressure is quite low when we have detected the patient. Could we have detected him early, especially given the patient was a high-risk patient after a surgery? The patient had a bowel surgery, an ASA2 patient, diabetes, hypertension, and smoking high-risk patient. So how could we have detected this early?
Yes, so it's obvious that we identified this patient at a later stage, because these symptoms or signs would not manifest suddenly. So if we had the tracing of this patient monitoring chart, we would be able to identify that the patient has had developed symptoms early than this time of diagnosis. As we discussed, this sepsis is a time-dependent syndrome. So early identification is the key to success to reduce morbidity and mortality. So we have missed a lot of hours after golden hour. So this patient definitely would have higher morbidity and mortality, because we could not catch him at the correct place, even though the screening tools were available. So yes, of course, we can use this national early warning scores, which is also recommended in the current guidelines. So this has very simple physiological parameters such as respiratory rate, saturation, temperature, blood pressure, heart rate, and level of consciousness, which you can apply to the patient at the bedside. So you have a certain specific mark given to this patient according to the physiological parameter, and according to the mark, you have a frequency of observation in this patient. So if this mark come to a particular trigger point, a cascade of reactions would be triggered, so that the level of care which is coming to see this patient would be different. So if we have applied this national learning warning score to this patient, we could have definitely identified this patient quite early, and would have started resuscitation early, so that he would have less morbidity and mortality. So national learning warning score is also recommended as a screening tool in the current guidelines.
Yeah, so unfortunately, this patient was not monitored throughout, and then we suddenly detected when the patient blood pressure has crashed. Now, at that time, the patient's vital parameters are marked here on this news chart. We can now add the score that is given for each parameter. With that, his new score comes to 10, right? More than 7 or more than 7 is the real alert zone, right? It's a red zone. So patient having a score of 10 is doing pretty bad. So according to this his new score recommendations, the patient needs immediate assessment and resuscitation and escalation of care to the ICU. So in summary, we have now identified that there is no single gold standard test to diagnose sepsis. And these tools are for us to, these tools are there for us to be alert if something is going wrong. Most important thing about using tools is that our clinical judgment is really important, and these screening tools will support our clinical judgment. Right? So we should have a very good knowledge about all these different types of scoring systems, their advantages, their disadvantages, and we should also not forget who the highest patients are, in whom we should be keeping a close eye, and we should have a very low threshold for monitoring such patients. Anushka, sometimes when we search internet, we hear about some other screening tools as well, Robson score, modified Robson, and what should we know about this?
Yes, this Robson or modified Robson or BS 939, they are not included in this 2021 guidelines, but it has been used. It has been used in OPD or pre-hospital setup to catch the patients who have this likelihood of having sepsis. So you can use this. It also uses simple parameters, but we just mentioned them just to have a broad overview. So if you take this review of trigger tools to support the early identification of sepsis in healthcare settings, the SIRS, QSOFA, and the NEWS have this a strong level of evidence and evidence quality. So you should use SIRS, QSOFA, and NEWS. And mind you, we should say that NEWS, it has their own minimal frequency of monitoring when you encounter with a particular scoring. But of course, you can alter this frequency of monitoring if the patient is a high-risk patient, as Amila said, following a major trauma, major surgery, severe burns, dialysis, immunosuppressed patient. So if you can alter your monitoring frequency with your clinical judgment, with your decision, so you could catch these patients early using these screening tools.
Yes, Anushka. Now, thank you very much. Now, this patient, I said that some investigations were sent as well, right? So we are now going to talk about the biomarkers in recognition of sepsis. Dr. Mahen has now very nicely explained us about how we can use the CRP values and then the procalcitonin values and their importance in management of sepsis. Now, this patient is a post-operative patient. So what will be the C-reactive protein value and procalcitonin value, and how specific and sensitive those would be, Dr. Mahen?
Right. Thank you. I think you can hear me, no? Yeah.
Yes.
Yeah. So now, again, when traumatic patient, now this is a post-surgical patient, so you can consider it as some sort of a trauma. So there will be invariably, there will be a response, WBC-DC response. So that means with the trauma, it will goes up. And again, surgical trauma, it enhances the liver activity and also releases C-reactive protein. So with the surgery, backdrop of surgery, the C-reactive protein and also WBC-DC invariably it will change. C-reactive protein level will go up. And when you consider procalcitonin, so it also can go up in major surgeries, but not always. So if the surgery is let's say, not sort of a huge surgery, taken a lot of time, so procalcitonin will be normal, but procalcitonin 2 can go high up if the surgery, if there is a lot of tissue damage and also a lot of transfusions, complicated surgery, procalcitonin can go up.
Right. Thank you. So we have already sent blood for the CRP and the procalcitonin levels and the full blood count as well, and we are still awaiting their investigation findings. And we have done an initial screening. Now it is really likely that the patient has sepsis. So if I am to tell you again how the patient was resuscitated, and I'm going to give you some specific points here. The patient's blood was taken for a blood gas. and initiate fluid bolus of 500 ml started. And the patient was also given IV meropenem 1 gram stat dose. Now, Anushka, do you think that we have done the initial resuscitation correctly? Have we, adhered to this bundle care?
Yeah, so yes, he has had the resuscitation very correctly, but only thing is that the identification of this patient was delayed, so the golden hour was missed. So we will talk about these 2021 guidelines for management of sepsis, and must tell you that they specifically say that these recommendations will not replace the clinician's decision making. It's just best practice guidelines to make sure that the patient has the best outcomes that as clinicians when we use these guidelines as a protocol. So we all know that when we talk about initial resuscitation, we talk about the sepsis care bundle. So you have a set of interventions or things which you have to implement together for you to have a best outcome in a specified time frame. So all these interventions are evidence-based. So if you do all these together at a specific time frame, the outcomes, the morbidity and mortality would be less and would have better survival. So 2021 guidelines still emphasize on this 2018 amendment 1 hour bundle, with the clear intention of beginning the resuscitation and management immediately, taking sepsis as a medical emergency. So for us to have a 1 hour bundle, we have to know where the time zero starts. So it is at the time where you diagnose the patient or where you screen the patient as to have sepsis. And if the patient is referred to you from another setup, you have to go, if you can, go back to his monitoring charts and to identify where he has had this developed his symptoms, which would tally with the sepsis. That is the time where the patient's time zero has started. And so you should not delay your resuscitation pending the ICU admission. Wherever the patient is, you should start your resuscitation. So we'll come to this 1 hour bundle. It has not changed in 2021 guidelines. You measure lactate, you initiate the fluid resuscitation, and you obtain cultures and administer antibiotics. And of course, within the 1 hour itself, first hour itself, you apply a vasopressor if the patient is persistently hypotensive to have a MAC target of more than 65, and then you remeasure the lactate level if it is increased initially. So we will go to the
Yes, Anushka. Now, we have to adhere to this bundle care. We will talk about, each bundle separately now. Now, our patient was started on 500 ml of fluid bolus, and it was a normal saline bolus. And the ward staff wanted to give up to 30 ml per kg fluid. Now, Anushka, how do we give fluid in sepsis now? Is this the way that we should start and gradually escalate? What do you think?
Yes, so initial fluid resuscitation, you should start if there is a sepsis-induced hypoperfusion. So in this patient, definitely there is hypotension, hypoperfusion. So yes, 30 ml per kg is still being recommended in 2021 guidelines of intravenous fluid. You start it within the first hour, and then you spread it within 3 hours. This 30 ml per kg over 3 hours is a rough guide. It is a weak recommendation. So one might wonder where this 30 ml per kg came from. Well, it is based on this observational evidence only. Unfortunately, there are no prospective interventions to say how much of fluid in initial resuscitation for sepsis and septic shock. There was one study saying that the patient would have increased morbidity, mortality, and delayed resolution of hypotension because they were not transfused with 30 ml per kg within 3 hours. But however, this 30 ml per kg may have come from this process from his RISE trials, and then there had been meta-analysis into these trials, and they all have been using 30 ml per kg as a pre-randomization volume. So this was recommended or suggested in the 2021 guidelines as well. But we must emphasize that it is just a rough guide. I may not want 30 ml per kg for my resuscitation if I had sepsis or septic shock, and the other patient would need more than 30 ml per kg of resuscitation, because this sepsis is a spectrum. The place where the patient would lie is dependent on the individual patient according to their clinical picture. Yes, now we have this patient. So how much of fluids should we give first? So septic shock or sepsis is definitely a status where there is a fluid deficit. There's 99% of the time they will be fluid responders. So as soon as you identify, you start with fluid resuscitation. The recommendation is to give around 10 ml per kg in the first 45 minutes to 1 hour. So you straight away start at 10 ml per kg. Say if the patient of this ideal body weight, if his patient was 80 kilos, so you can set your rate at say 800 ml within first 45 minutes. And then while you resuscitate this patient, you just take a background history, whether the patient has had deficits, ongoing losses, vomiting, diarrhea, or whether the patient has, your suspicion is a pneumonia, and whether the patient have other comorbidities such as cardiac diseases, renal problems. So likewise, you analyze, and then you can increase or decrease your rate depending on the findings. So you may give more than 10 ml per kg, maybe 15 ml per kg, if there are ongoing losses, especially if there are abdominal sepsis, and your clinical markers refilling time is high, increased lactate, so there is mottled skin. But you may have to go down in your rate, maybe 8 or maybe 7, if the patient is increasing in his tachypnea, or if the patient start to fail in oxygen saturation, suggesting that the patient is not at this Frank-Starling steep part of the curve. So yes, you can straight away start with 10 ml per kg. But beyond that, as I've said, 30 ml per kg is just a rough guide. Beyond that, resuscitation has to be individualized, because one size does not fit all.
Okay, Anushka. Now, our patient has now already received about 1 liter of fluid, but still the capillary refilling time is more than 2, and blood pressure still remains low. MAP is less than 65, which is 60 now. And the patient is still tachycardic. Now, I really wonder whether my patient need more fluid. Are there any tests to see whether the patient will respond to more fluids, especially that can be applied in the ward setup?
Yes, so now this fluid responsiveness now comes into play. Now we have given initial fluid resuscitation to the patient, and further fluids has to be definitely evaluated to see if the patient is fluid responsive. So we will see why we need to assess fluid responsiveness, when and how. So why we need to assess fluid responsiveness is sometimes these patients will not be in the Frank-Starling curve, because even they have found that some patients are in the shock but are not fluid responsive. And if you give fluids to these patients, it would be harmful, especially if there is a positive fluid balance, and if the patient has a background of pneumonia, would increase this morbidity and mortality. And of course, you have to assess this fluid responsiveness, because it has shown that it is a dynamic process. So when to assess? If you give initial 10 ml per kg, and then if the patient is still hypotensive, yes, you have to assess and see if the patient is fluid responsive. If you keep to assess it at the end of 3 hours after you give 30 ml per kg, it might be too late. So when? After the patient has had about 10 ml per kg, and if the patient is still hypotensive. So how you assess fluid responsiveness is by using static parameters and dynamic parameters. Static parameters, it has continuously been proven that it would not be beneficial to use them only, because they are not reliable. So what we have to use is the dynamic parameters. So they issue a weak recommendation on use of dynamic parameters, specifically using this passive leg rest test of fluid bolus, looking at the stroke volume variation, pulse pressure variation of the echocardiography where available. So unfortunately, these things are not available in the ward setup. And I'll just add a word for this dynamic fluid responsiveness. So just keep in mind, it has improved survival benefits if we use this dynamic fluid responsiveness tests to assess the fluid responsiveness. Yeah.
Yeah, so now the problem is, what are the tests that we can do in the ward setup or in a low resource setup, isn't it? What are the recommendations that they give with regard to, ward setup fluid responsive assessment, Anushka?
Yes, these current guidelines recommend use of passive leg raise test, but the conventional method is use of this cardiac output monitoring. But you can use this passive leg raise test to see a change in the pulse pressure. So that is the systole minus diastole. So you measure the pulse pressure, and then you do the passive leg raise test, and then you do the pulse pressure measurement again. If the change is more than 15%, it would suggest that the patient is fluid responsive. So mind you, this is inferior to this conventional passive leg raise test by use of cardiac output monitoring, but still they would recommend it to be used in low resource setup. So we will talk about this passive leg raise test, how we do it in a proper way when the patient comes to the ICU. Second thing which they recommend is to use the capillary refill time. So this Andromeda shock trial, they have shown some reduction in mortality and SOFA scores by the use of this capillary refill time. But unfortunately, the evidence has had no statistical significance. But still, they issue a weak recommendation to use capillary refill time by the bedside because it has these said advantages. So second one is capillary refill time. Apart from that, you can use lactate levels, and which we will discuss later. And then you can use these skin mottling scores. Well, if the patient has a light complexion, you can use this skin mottling scores as well. You give a fluid bolus and you see if this mottling of skin is disappearing. That if the patient has disappeared in skin mottles, you would say that the patient is fluid responsive. And you can use these temperature gradients as well. And most importantly, the other thing is your clinical judgment. If the patient has worsening of tachypnea, I'm sorry, this has to be tachypnea, and failing saturation, you would not think of giving further fluids to this patient.
Thanks, Anushka. Now, this patient has capillary refilling time again still more than 2 seconds, and the ward staff have done a passive leg raising. And the blood pressures, they have noted that there is a significant pulse pressure change. Blood pressure, which was 85 by 50, has now gone up to 95 by 50. They have already given 1000 ml of fluid. Now, do you think that the patient was initially started on normal saline? Do you think that it is a good choice, or could we have used something else?
Yes, for the rich fluid in resuscitation of sepsis, whether it's balanced crystalloids or 0.9 saline, well, they have issued a weak recommendation to use balanced crystalloids rather than 0.9 saline. There had been various studies on this split study, SOL study, but none of them has proven any beneficence over balanced crystalloid or 0.9 saline, except for this one study, SMART study, but it was a single center non-randomized, non-blinded study. So they still recommend to use balanced crystalloids as a weak recommendation, unless if not the patient is having a head injury. If the patient is having head injury, of course, you will have to go for 0.9 saline. Otherwise, if you have resources, you can use balanced crystalloids. So apart from that, there are other studies such as basic study and this plasma-light versus saline study, which is yet to come. So with that, the 2021 guideline may change in the future, which fluid to be given. And with regards to albumin, theoretically it would increase the colloid oncotic pressure, but actually they have given a weak recommendation if the patient receives a lot of fluid volume, and if you think the patient further needs volume, if he's further fluid responsive, you can give albumin. But they have a strong recommendation against use of starches or gelatins.
Right. Now, this patient had an initial lactate level of 4.5, Anushka. Now they have done a repeat blood gas and the lactate has dropped from 4.5 to 3.8. Now, what is the importance of measuring lactate in septic patients?
Yes, lactase has many implications when you talk about sepsis. It is a biomarker of tissue hypoxia, mind you, not a direct measure of tissue perfusion. So lactate levels has to be interpreted according to the patient's clinical picture, as I have said before. So in LQ so far, you can use lactate for the diagnosis, and you need lactate for diagnosis of septic shock as well. And they have issued a weak recommendation to use lactate levels rather than not using lactate levels in a patient who has had already limited lactate levels. So if you have the facility, you can guide your resuscitation according to the reduction in the lactate. And then, but mind you, keep in mind that lactate level will not come to the baseline sooner. It will take time, but reduction in lactate levels, you can use it as a guidance for your resuscitation.
Right. Now we have spoken about 2 bundles in our bundle care. Now, the other important thing about resuscitating these patients is to take blood cultures and give broad spectrum antibiotics. Now our patient was given IV meropenem 1 gram after taking blood for cultures. Dr. Mahen, what do you think about starting meropenem? Is it the right drug or is it the right dose? And is there a specific guidelines given in the recent 2021 about timing of antibiotics?
Yeah. So now since patient is in shock and you can't wait any longer till the the culture results are available, and at the same time you can't delay the treatment in view of collection of blood cultures. So in this scenario, it need to be collected from 2 different sites, from two sites at the same time, and you should start preferably with a broad spectrum antibiotics. And if you need a further expansion of your coverage, you can add something to that. So that again, it depends on the syndrome that you are, infective syndrome that you are expecting. Now, since this is an intra-abdominal issue, I think this is an intra-abdominal, no?
Yes. Yeah.
So intra-abdominal. So you can either give meropenem alone or meropenem in combination with metronidazole. But what you have to give, you have to give it early in the course of illness. Another thing here, because of the blood pressure, patient's blood pressure is low in state of low perfusion, they might have to think of giving a bolus to fill the body fluid compartments. So that means sometimes you might have to give a 1 dose of 1 gram of meropenem within 30 minutes, and as soon as you stop, you finish the dose, you could have started the meropenem as a infusion, right? So that means initially there has to be 2 doses in order to fill all the body fluid compartments. Now, when the infection is there, infection is at the interstitial fluid compartment level. So you are giving a drug into the blood compartment. So therefore, the drug has to go to interstitial fluid compartment where the organism is. So for that, you have to give everything together: the fluid resuscitation, the antibiotic loading, blood collection, everything. So I think in this scenario, giving meropenem is okay, all right.
Right. Okay, thank you very much, Dr. Mahen. Now our patient was given antibiotics as well. Now there is a little bit of a problem. Now we have already given 1,500 ml of fluid, but the blood pressure is still low. And what they did was they inserted a white bore cannula to the neck and started on a noradrenaline infusion to keep the map. Now, Anushka, do you think it is a good practice to start noradrenaline peripherally? Is it recommended in the current guidelines?
Yes, you have to start your vasopressors as soon as if the patient is not making it to the target map of 65, because if you delay to keep the map at 65, you have other end organ consequences. So it is a correct practice. So you have to start noradrenaline or any vasopressors in the first hour itself to keep the map at 65. So first line recommendation is always noradrenaline because it has improved survival or reduction in the mortality and reduction in the arrhythmia compared with the other inotropes or vasopressors available. So first line noradrenaline, and you can apply it from the peripheral line. The current guidelines, they recommend you can start it from any cannula which is properly placed proximal to the cubital fossa. So neckline would be fine, or any cannula proximal to the antecubital fossa, just for a short period until the patient is settled with the central venous catheter. This is to emphasize that you have to start the inotropes early, the vasopressors early, to make sure that the patient has a map of 65 according to the 1 hour bundle.
Okay, Anushka. Now we had sent some investigations. They have arrived. Now the WBC count is 20,000 and the CRP is 264. Dr. Mahin, how can we interpret this CRP value, 264?
Yeah, so CRP reflects some inflammation. It reflects that there is something going wrong in this patient. So it may be sepsis or may be related to surgery. So if you follow it up with another one, maybe after 2 days, you will see the trend. So therefore, a single standalone value of 265 in a post-operative patient, it's very difficult to interpret. But if this is a normal person who are coming with a infection only, you can have a rough guide. If you get a single value of more than 60 or increase of 40, you can consider it as presumptive of some sort of an infectious insult. Because of this patient had a history of surgery, so you can't interpret this value as a standalone value.
Okay, right. Okay, thank you very much. Now, we had a patient who was critically ill, and we screened the patient for possible sepsis, and we decided that there is a very high chance that the patient has sepsis. And then we started our resuscitation bundle and continued treatment according to the resuscitation bundle, and we got some investigations which are again suggestive of sepsis. And this patient, we remember that the patient had a very high news score, and the ICU team was called, and they wanted to admit the patient to the ICU. And according to the 2021 recommendations, they suggest admitting the patient to the ICU within 6 hours. So our patient luckily had an ICU bed and got into the ICU. Now, Dr. Harini is our ICU consultant, and Dr. Harini, when the patient admitted to the ICU, the patient was maintaining his airway and was on 15 liters of oxygen by this time. And the blood pressure was 90/55 because they have already started some noradrenaline with peripheral cannula. And in the ICU, they decided to insert a central line and continue the noradrenaline infusion, and they continued patients monitoring vital parameters, urine output and lactate levels as well. And they did a chest X-ray and also got the CT abdomen, contrast CT abdomen done to rule out for a possible source for sepsis. Now, Dr. Harini, what can you say about further hemodynamic management in this patient? Now, this patient already had 1,500 of fluid, already started on a vasopressor. What do the current guidelines say about management of hemodynamics in the ICU?
Yeah, I think we had some resuscitation, initial resuscitation of this patient we had done. So hemodynamics in the ward setup, we discussed that we can have non-invasive blood pressure, pulse rate, and volume. We can assess capillary filling time, and we can have a passive regress test. and the static parameters such as, even though it says CVP, that is also can be assessed in ward setup as well as in ICU, though it says crude, but it gives some idea about the assessment. Coming into the ICU, that we can have some more sophisticated monitoring. So we can have some CCTV cameras in our ICUs, right? So you know that we can encounter some sophisticated monitoring, like we can have rapid lead core, we can have flow track. It says that the cardiac output monitoring facilities, the modalities available, of course, you can have it. Having said that, now the ICU is a where area we can have very free. We use ultrasound in IVC collapsibility. I'm not saying it is not confined only to the ICU, but in a ward setup, that's one non-invasive technique that you can use to assess the hemodynamics. Yes, you can use it both in ICU as well as in the ward setup. IVC collapsibility is one very feasible and bedside test that you can do. And at the same time, if you have a central line, now the patient is coming into the ICU, that we had a CVP line and we have the trained assessment, and you can have the FICE, focused intensive care echo you can do. So with doing that echo, you can see the ventricular functions and you can see the collapsibility of the ventricles. So the kissing ventricles are present. So that gives you the IVC collapsibility, FICE, and everything together with arterial line with some pulse pressure variation, some stroke volume variation. So all together gives you very, very good idea about the overall hemodynamics of the patient. So as in this graph, we can see the pulse pressure, stroke volume, the stroke volume variation, the maximum and the differences, and the pulse pressure variation. That gives you very good idea about the fluid responsiveness of the patient, that whether you can give some fluids of patients coming into who are critical actually.
Yes, now Harini,
Right. So I think the patients, if the blood pressure is still dropping or the further dropping, so arterial line. So you can have as our patient is admitted to the ICU, we have started arterial line. So the invasive blood pressure monitoring, that is some place, it's a gold standard actually. Like such patients, beat to beat blood pressure monitoring is very, very important. So that we have initiated in our resuscitation monitoring as with the invasive monitoring as well. Yes, Samila.
Yes, Harini, now the problem is blood pressure is further dropping. We have inserted an arterial cannula as well, but we noted that there is no pulse pressure variation or stroke volume variation either with the passive leg raising or with fluid boluses. And the capillary refilling time is also more than 2 seconds. Do you think that I should now add a vasopressor or an inotrope?
Exactly. I just want to highlight some important point here now. It's a 3.7 lactate. Now the previous it was around 4.5. So that we could say something very good resuscitation. So that we had initial phase. So now we can say now the patient, now you said that a pulse pressure variation is less, no, stroke volume variation is no, quite such variation. So that means intravascular compartment is already filled. So that's a very good sign to say that the patient is intravascularly filled. But having said that, the patient is still, the blood pressure is low, isn't it? So that we have to have some modality. I agree with you that you have to have second vasopressor or you have to start second inotrope as well. Now, coming back to the guideline that it says, first line is the noradrenaline. Of course, we have discussed in a septic patient, sepsis or the septic shock patient. So the targeting map of 65 mercury millimeters. And you can consider invasive monitoring to target the values, pressure values, but in ward setup, you are not comfortable or there are no facilities in you to use it in the ward setup. Luckily, now the patient is in ICU that you can have arterial monitoring and start arterial invasive monitoring as well. So you have started, central line is not available in the ward setup, it seems. So you have started with the peripheral cannula, like neck cannula, external jugular, and our antecubital fossa cannula that you have started peripheral to the noradrenaline to make sure that have a map of 65. So you can consider if it is map is still not 65 with adequate fluid resuscitation. Of course, you can consider adding second inotrope that you can add vasopressin as well. So second line, vasopressin, yes. So having vasopressin as a second line, if the patient still, now the cardiac dysfunction still persistent, the cardiac dysfunction with persistent hypoperfusion, even though you have filled the patient adequately with the volume replacement, there you can consider of adding dobutamine, or you can switch into the epinephrine as a drug of choice there. For you, it's an idea of now the adequately filled vasoconstricted blood pressure, systemic vascular resistance is high with noradrenaline. But for you to have the perfusion, you have to have some sort of vasodilatation, which will be given by the dobutamine, adding dobutamine as well, or you can have some effect with beta action by you can get it from adding adrenaline. So recommended to use norepinephrine as the first line. So we are stressing it again and again because that's a guideline 2021, even 2018 guidelines also, they recommended as a first line is the noradrenaline. And the second, if there is, it's a very strong recommendation actually. With added, you can have the rest of the vasopressors you can add. Now, if there is a settings, if you have a noradrenaline or norepinephrine is not available, you can go with the alternative such as epinephrine, or you can have dobutamine as an alternative. But it's recommended for all the time to have the availability of the noradrenaline in everywhere, the settings to have the as a first line. Now, now the patients who are the risk of arrhythmias, you have to have a very good attention when you are using dopamine and epinephrine, because it's a risk of arrhythmias are there. So you have to be very cautious. You have to pay your special attention when you are giving such. So in guidelines, it's suggested adding vasopressin instead of escalating the dose of norepinephrine. So now you said that now our patient, the blood pressure is not picking up. So that's why you're asking whether to go for the second inotrope or vasopressor. So rather than increasing the dose of noradrenaline, so it's good to add the vasopressin as a second line or the second drug, where if your norepinephrine or the noradrenaline dose exceeding a range of between 0.25 to 0.5 mg per kg minute. So it's good for you to start the vasopressin rather than going beyond 0.5 mg per kg per minute. Now, vasopressin, now we know that it's a catecholamine sparing effect. It has norepinephrine and vasopressin. It says that's evidence that both together has reduced the mortality effects as well. Now, combination has a lower risk of arrhythmias than norepinephrine alone. Now, if the patient is not responding, now the responding with the combination of norepinephrine and vasopressin, if not responding, so you can add epinephrine as well. If you need to maintain the blood pressure, that's where our initial targets, have to maintain the targets at least 65 mercury millimeters of a MAC. Now, now the patients, adult patients with cardiac with septic shock and the cardiac dysfunction with persistent hyperperfusion. Now, as we have said, despite of as our patient adequate fluid volume resuscitation and with the arterial blood pressure, they suggest to adding dobutamine to norepinephrine or using epinephrine alone. So what he says that we have said that now noradrenaline is also added. So you can add dobutamine. If there is still the perfusion is dysfunction, it's not adequate. So you can switch both off and you can go for the adrenaline alone according to the guidelines. I think that's what we have to do in inotropic point of view.
Thank you, Harini. Now our patient's blood pressure, was resuscitated hemodynamically. Now the patient is relatively stable with the noradrenaline and vasopressin. And the CT abdomen report came up. Unfortunately, the patient has moderate ascites and distended small and large bowel loop. So there is an acute abdomen, and the surgical team arranged an urgent laparotomy after resuscitation. So they found that there was leakage from the anastomotic site and there was fecal soiling and they washed the peritoneum and a colostomy was done. And during surgery, during anesthesia, they continued the fluid resuscitation, noradrenaline and vasopressin, and brought the patient back to the ICU. And the patient was brought back to the ICU with the tube in. And this patient also had a chest X-ray, and there were, basal consolidation as well. So it is really important to detect the source of infection and treat as Dr. Mahen initially also explained, we have to treat the infection, give antibiotics, as well as we have to identify the source and then drain it if possible. So what are the recommendations about source control, Harini?
Yeah, so it says recommended to identify where the culprit organ or where the culprit area, the specific anatomical, you have to come for a specific anatomical diagnosis of where the infection is. And if you have to intervene early as possible. Now, luckily, like our patient, so the abdomen was, they found having perforated or the leakage abdomen. So the abdominal sepsis, that the culprit area was the abdomen. So they have done it to assess it and to do the necessary action, right? So having said that, but your patient, you have to resuscitate and you have to stabilize the patient as much as possible, as early as possible, before you sending the patient to the theater or for a source control.
Right.
Yeah.
So our patient was brought back to the ICU with the tube in. And the surgery was done late night, and they planned to continue ventilation overnight and try to wean and extubate the next day. Are there any specific, recommendations on ventilatory management in patients with sepsis, Dr. Harini?
Yeah, exactly. So the ventilation, they have started saying that there are talking about the oxygen targets, non-invasive ventilation. If I say that oxygen targets, actually, now there are conventional ways of giving oxygen. Now our patient is intubated. So if it is not such intubated, if we say that the patient is not intubated, so there are, rather than even though with the patient with face mask or patient with not intubated or intubated, so the conventional, the oxygen target, they normally said about PO2 maintaining around 55 to 70 with a saturation of 88 to 92% in a such critically ill patient. But it's not always all the things are tally with the patient or individualized. It has to be individualized based oxygen targets. Now their recommendation, it says there is insufficient data or the evidence to go for the recommendations to see conservative oxygen targets in adult with sepsis. So you can't exactly say now this is the target, PaO2 is for 55 to 75, the saturation is 88 to 92, but you have to individualize management of the patient with about oxygen targets. Now there are some studies, actually there is some study called ICU ROCKS trial and some study called LOCA2 studies. They have said that there are the conclusion that exactly you can't say that you can adhere to the conservative oxygen targets. That is best evidence for you to go for a individualized based oxygen, achieving oxygen targets. And the non-invasive ventilation and high flow oxygen therapy. So they have said recommended to have the high flow oxygen therapy over the non-invasive ventilation, actually. Now, rather than using Venturi, face mask with non-breathing bag, it's good for you to have the non-invasive ventilation or a high flow. Comparatively, regarding the both techniques that reduce the incidences of intubation, that gives you a very good, now, for example, with the non-invasive, it gives a very good patient work of breathing will be reduced, and that give you the very good PEEP, and coming into high flow oxygenation, that humidification, warming of the air. So every possibilities are there. But comparatively, the normal conventional the face mask and the nasal prongs, it's better for you to have the non-invasive ventilation or high flow. In between those two, non-invasive and the high flow oxygen therapy. So it's recommended in the 2021 guidelines for you to go for a high flow nasal oxygen therapy than the non-invasive ventilation, though it's a weak recommendation. So you can go it because there are advantages, because the patient, its compliance would be better, that high flow that will be give some sort of patient can talk, and patient can give a involving the compliance would be better. So therefore they recommended to have a high flow nasal cannula with the high flow oxygen rather than going with the rest of the modalities. Now coming to the ventilations targets. Now our patient is intubated, intubated and coming into the theater, coming from the theater to the ICU. So you have to have the protective lung ventilation in like patients with acute respiratory distress syndrome. Now there is no difference in the guidelines 2018 and 2021. So there is no differences. Same, the recommendations are there. You have to go for a low tidal volumes. You have to target around 6 mils per kg, and you are not to exceed the plateau pressure more than 30 centimeter water. Or beyond, you are not supposed to target. So you have to have the protective lung ventilation to protect the baby lung, which is unaffected lung in such patient. So you can have the recruitment maneuvers. So what are the recruitment maneuvers? Normally what we do actually, so you can have this traditional recruitment maneuvers such as application of sustained continuous positive airway pressure, like you can have 30 to 40 centimeter watt up to 30 to 40 seconds. So you can still recommend that in 2018, 2021, it's also recommended you can have recruitment maneuvers with lung incremental PEEP levels, but it is not recommended for you to, it's recommended for you to have this lung recruitment maneuvers as well. So now coming into the prone ventilation. So it's 2018 is also there, 2021 is also there, the prone ventilation. It's recommended the patients who are with ARDS. Now, luckily our patient, he didn't have ARDS picture, but if the patient is having ARDS picture, so you can go for the prone ventilation where within first 36 hours of intubation of the patient, you can go for a 12 hours of prone ventilation. So it's also recommended. There are the strong recommendations and moderate quality evidence is there for a prone ventilation for a better outcome of the patient. And talking about the neuromuscular blocking agents, so most of the time we do go ahead with the neuromuscular blocking agents because for a purpose of intubation and maintaining of the ventilation of the patient, that will give a very good compliance. The chest compliance will be enhanced and the patient synchrony will be maintained. The patient struggle against the ventilator will be taken off. So at the same time, it will reduce the airway pressure. So there are advantages of using neuromuscular blocking agents with adequate sedation as well. So, but guidelines it as the boluses. And there are some recommendations for ECMO. So they have, there are big, I mean, there is no evidence actually to say that the place of ECMO actually. So because the patients who are with ARDS, which are not coming out or not responding for this normal conventional mechanical ventilation, so which are failing such, they can have with the VV ECMO or the veno-venous ECMO they can go for that study, but still the studies, there are lack of evidence for these recommendations.
Right, Harini. So you gave a very broad aspect about ventilatory management in a septic patient, especially if they have developed ARDS. Now, this patient was started on a steroid as well, Harini. Do you think steroid was started and to give steroid, and what are the other additional things that we should consider in managing this patient in the ICU?
Yeah, there are additional therapies. I will first discuss with the steroids actually. Now we can start hydrocortisone steroids where its dose come as 200 milligrams daily dose you can give. But there is, you can give up to 50 QDS or you can give us the infusion. There is no hard and fast say that this is superior to either, which depends on your choice. If you're comfortable with 50 QDS or you can comfortable with infusion, depends on clinical choice, you can go either. But when the question comes, when you are supposed to start this infusion or the 50 days, right? So it comes when the dose of adrenaline or noradrenaline, it's going beyond 0.25 mics per kg per minute, with at least 4 hours after initiation of noradrenaline. So that's the time where you have to start hydrocortisone, the steroids, corticosteroid infusion or a 50 QDS. The same time, if I go further, the additional therapies, you can give the RBC, the blood transfusion you can consider, but you are not enthusiastically giving blood to all the patients at all the time. There are specific indications where you can go. Normally your target is maintaining about 70. That means hemoglobin level 70 grams per liter, 7 grams per deciliter. So you can go that target. Beyond that, you can give blood, but not to achieve the higher targets like 9, 10, 11, the normal targets you are not supposed to achieve. But there are some patients like recent MI, the patients with severe hypoxemia, where you know that hemoglobin is oxygen carrier, that you have to have a hemoglobin to carry oxygen. So the severe hypoxemia, yes, of course you have to give blood transfusions. Or there is some evidence of acute hemorrhage, obvious that you have to give blood. So exceptions are there, but normally you are not supposed to give all the patients blood if the patients are, the HB values is not less than 7. And there is a place for ulcer prophylaxis if the patient is with a risk of GI bleed. So you are supposed to start for the ulcer prophylaxis. This was talking about in 2018 guidelines as well. This is not a new coming into the guideline. And venous thromboprophylaxis, yes, of course, you have to go for the pharmacological prophylaxis. The choice they recommended according to guideline, low molecular weight heparin or unfractionated heparin, either depends on your choice. And you can have mechanical prophylaxis devices such as mechanical compression devices. Either if the pharmacological method that you can use, go for that, then you don't need to have the mechanical compression devices as such, both together you don't have. But there are some patients that you can't go for the pharmacological method, such as enoxaparin or the unfractionated heparin, that you can't give. We'll say now the bleeding patients immediately just after surgery, we'll say the platelets are very low, INR is high rising. So there is evidence of coagulopathy is going on. Such patient, you can't go with the enoxaparin or the unfractionated heparin. In such patient, there is a place for using mechanical ventilation, mechanical devices, but it's not both together. It's not recommended because it's a low-income countries. It says the using devices such as mechanical compression devices is very cost-effective. So that's it's expensive. So therefore, that either is they recommend. And coming into other measures now, if the patient is going for a renal failure, acute AKI, then you can consider of the renal replacement. There is no difference between whether you go for a continuous renal replacement or intermittent hemodialysis. That depends on the patient clinical condition, actually stability of the patient, hemodynamic status of patient. You can decide continuous or intermittent renal replacement. So there is not superior each on other. So both you can, whatever depend on the patient clinical condition, that you can consider of the renal replacement therapy. But having said that, if there is only an indication where you have to go for a renal replacement, but not impending renal failure can be a possibility. That is not an indication. Only if there is an indication that you can have to go for a renal replacement therapy. And we know that in our ICU that we have to have the glucose control as well. It's recommended for you to have more than less than 180 milligrams per deciliter. If it is going beyond 180, yes, you can start soluble insulin infusion according to the algorithm. But you are not supposed to lower the glucose level. The patients are not supposed to go beyond 144 level. So you have to maintain 144 to 180. Now, previous it was talking about 110. Now, new guideline, it says 144, because if it is level around 110, it says they are more prone to get hypoglycemia. So that's why they have recommended to maintain the glucose level 144 to 180. Now, place for vitamin C. Now, previously there were some studies that using IV vitamin C, hydrocortisone, thiamine in treatment of patients. So it's evidence that says there is no the benefits over using IV vitamin C ascorbic acid for treating of the patient for a better outcome. So normally, the hospitals like us, we also don't have the this as IV ascorbic or the vitamin C available in our setup as well. Now, bicarbonate therapy. So are we going to give the bicarbonate to all the patients? So sometimes you may think to increase the blood pressure, bicarbonate has a place. But it's suggested against that, it's not recommended to use sodium bicarbonate therapy to improve the hemodynamics or to reduce the vasopressor requirement of the patient. There are suggestions only when you are supposed to do the bicarbonate, where is pH becoming less than 7.2 and AKI, according to the acute kidney injury network, stage of 2 or 3, where there you can consider giving the bicarbonate therapy. So otherwise, you are not supposed to give the bicarbonate to maintain the hemodynamics or reduce the vasopressor requirement. Nutrition. Yes, of course, you are not supposed to starve the patient. Nutrition has a very good place in our ICU, especially such critically ill septic patient. So you have to feed the patient early as possible. Recommendation is to have the enteral feeding at least early, where is within 72 hours period. Now, our patient, we know that there are some limitations because the patient had anastomotic leakage and then the reconstruction is there. So in such time, you might be able to wait until 72 hours, but you have to start early as possible enteral feeding, because that will maintain the gut motility more physiological. So that will give the boost the patient's nutritional state. The immunity will be boosted up. So the patient recovery or patient mobilization, discharge from the ICU would be enhanced, expedited. So that's why the nutrition, though it's something commonly that we miss, that you have to pay much attention of such patients.
Yeah, Harini, now our patient luckily was extubated the next day, as you very nicely explained. The ventilatory management and the other additional management were also continued while giving fluid resuscitation, vasopressors and antibiotics. And the patient, we could gradually wean the vasopressors, and the patient was discharged to the ward after 3 days of intensive care. According to these 2021 guidelines, they specifically mention about having goals for management and also having a special discharge plan. What do they say about those, Harini?
Yeah, so rather than 2018 guidelines, now the 2021 guidelines, they included these goals of care as well, which is something which the low-income countries, more concerning of the low-income countries as well. So it's they are recommended using the goals, like what we are achieved, what are our targets, the prognosis of the patient, with the, if possible, with the patient, or else with the family members, because they're worried. Now, this might be one patient who is coming to ICU for us, but this is someone who is very precious, or their loved one who is coming to the ICU. So that we're supposed to discuss what we have done, advantages, disadvantages, things that we have done early rather than late. So it's recommended for you to have a discussion with the suggest that to go for this discussion as early as possible, at least within 72 hours rather than late. And there are some patients we are coming with the palliative care as well. So the patients, like we know that outcome would be not so good. So we know that they might be dying. So that such patients, so you have to have the palliative care plan for such patient. If there is a palliative team that you can ask them to come and review, give the palliative care plan, such as supportive treatment, addressing the patient's symptoms to minimize the patient's suffering. So such plans are also recommended in the 2021 guideline. And there are some patients, it's recommended to have the peer support groups, like the survivors, the patient who is sepsis and septic shock, was severely ill, who was going to die, but who have come out. So the survivors with the sepsis septic shock families, it's suggested to refer these peer support groups where is such referrals that you can do as well. And transitions of care as well. Now, there can be a handoff process of critically important information might be missing. So there should be some transitions of care should be there to minimize the bad outcome. So you have to have the transitions care of such patient, proper handing over, proper information, diverging of information among each other, which has suggested for you to have it in our patients as well. And the screening for this economic or the social support, where it's not previously discussed, which is discussing in new guidelines. So why it is important? Because it's very important for us to know about the social background of the patient, what's the economic status of the patient. Now in Sri Lanka, now this current crisis situation is very, very important for us to know what is the financial status of the patient, what's the household, the support a patient will get from the outsiders or their family, or are there any spiritual support, who is going to look after the patient. Such things, screening, economic or social support is recommended, because like sometimes, now this patient might be the substance abuse one. The patient might be very nutritionally deprived. So that might be the reason for them to go for the sepsis as well. Who knows? So in such patients, therefore, you have to have the screening for this economic and social supports. So that's why it's a low-income countries. This guidelines, 2021 guideline, it's more all over it was addressed. So it's very important for you to have a screening of such. And sepsis education for the patient is also one important thing. Now that is very important, because now what we have done, the ICU is a totally different environment. Or the next of it's a total different environment for them, even though it's a normal for us, because we day to day that we go into the ICUs. But so you have to have a sepsis education, what has happened, diagnosis, what sort of treatment that we have done. So what would be happen post of ICU, so the post sepsis syndromes, all sort of things that you have to discuss, and you have to make sure that family and the patients, if they are aware, the patient has to be aware as well. Now in decision making, it's a shared decision that we have to make. It's not now I told you, now this is it's not a single person game. It's a multidisciplinary approach. So everybody has to be involved in decision making. So it's not only the it's not only the VPs. It will be respiratory physicians, it will be microbiologists, it will be radiographers, radiologists, nutritionists, and dietitians and physiotherapists. Everyone have had a role in decision making, that you have to have a very good care plan of the patient. So what was supposed to do post-op ICU? So what are they supposed to discharge plan? So what sort of drugs, what are supposed to have a patient in home visits, how they are supposed to have the drugs. So are there any the support or everything that you have to have the shared decision making before discharge the patient to the home, the patient discharged from the hospital. And the same time, so you can have the post-discharge follow-up as well. So what is this post-discharge follow-up? Now, we know that this is a sepsis is something very, very burden, like, it's something very stressful event that so far they have come into. So in such patient, it's recommended for you to have a assessment clinics, post-discharge assessment of the patient to see how well they are, what is their physical state, what is their cognitive state, what is their emotional states, how are they coming out for this sepsis syndromes, post-sepsis syndrome, post-ICU symptoms are they delirious, are they recover from this post-ICU delirium, how is the pain, are they suffering from some sort of undue the pain or any sort of suffering is there. So everything has to be planned during discharge, and that has to be evaluated having a post-discharge follow-up. So that is recommended in 2021 guideline that they suggested to have it the patient who are with the ventilated more than 48 hours or patient who has stayed with us in ICU more than 72 hours. They suggested go for the referrals, the adequate referrals for the to see the patient and do necessary referrals as such. So at the end, what we expect is to discharge the patient or coming into our clinic patient who is someone who is dead, who almost dead actually, who is going to die. But we are supposed to discharge the patient from the hospital, from the ICU, who is smiling, who might be talking nicely, who is very happy, who is comfortable patient that going home like a nice person telling goodbye to all us. That's what we are supposed to do as according to the recommendations that we have discussed in 2021 guidelines as well. And we have come into with the case discussion scenario, how this patient went on, such sequences, and how we did initial resuscitation, management, antibiotics, source control, and all sort of things, sequences that how we are supposed to do to save the lives of our patient. Thank you very much. I don't say that this is three of us, but thank you very much for listening. Thank you.
Thank you, Harini. Thank you very much. Now, Dr. Bimal, now it is the time for us to give the final remarks in our webinar. What can you say, Dr. Bimal?
Thank you, Amila, Anushka, and Harini, for that extensive use of 2021 guideline, using that guideline, using to manage that patient who came to the ICU with a septic source in the abdomen, and how we can use that guideline to resuscitate, identify patient, resuscitate the patient, and then there onwards to manage the patient in the ICU and discharge the patient from the ICU to their wards and there onwards to the home, and how you should follow up those patients, septic patients who are discharged from critically setup, and how you prevent these kind of post-sepsis syndrome, because as I said at the beginning, it is one of the most common cause of readmission to the ICUs, and it is a highest cost burden for healthcare systems in the whole world. So actually, I hope that we have answered the most of the questions you have sent in via chat, and I thank you very much for answering those questions, Dr. Mahen and Dr. Anushka. And I thank again Dr. Mahen for giving that initial lecture and participating in the discussion of this patient. And then I also very much thankful to Dr. Amila Jayasinghe, Dr. Harini Jagoda, and Dr. Anushka Senaviratne taking us through this case scenario and show us how to apply these new guidelines effectively to manage this patient. And then so our intention was to give you the take-home message. Actually, what we wanted you to understand is that we need to identify early these septic patients by using various screening tools, and then initiate resuscitation bundle as soon as possible to prevent morbidity and mortality. And of course, not to say the cost bearings on that those patients who are going into morbidity and increasing with the increasing length of stay in the ICUs and the wards. And then this when you initiate these resuscitation bundles, you can make it length very short, and you can reduce the morbidity and reduce the cost burden on the individual itself as well as the healthcare system itself. So remember, every 1 hour delay in detecting and initiating treatment of sepsis patients can increase the mortality by 8%. And we are spending about more than not we, actually in the US alone, spending $62 billion per year for these patients. So worldwide cost for management of sepsis is in billions. So therefore, we should play a part in this management of sepsis and reduce the burden for the healthcare system as a whole and for those individuals. And again, thank you very much for listening to us and participating in this event. Hope you practice these guidelines in your working setup. And thank you very much again.
Okay.